Thank you. First of all, thank you very much for inviting me. It's an honor to speak here. I'm Dr. Wende. I'm a senior pain physician. I work in Hadassah University Teaching Hospital in Jerusalem, by the way, which is behind me, which is in the background. That's Hadassah in the middle of the mountains. I lead the treatment of musculoskeletal pain in the pain unit. And so I'm going to speak to you today about ambulatory treatment of partial rotator cuff tears with an emphasis on regenerative medicine. So we all know that the shoulder is the most mobile joint in the body, but this comes at the expense of stability. And also we get much more wear and tear. The shoulder joint is much more vulnerable to wear and tear of the various tendons and stretching of ligaments and so on and so forth. 1 second, Dubi. Oh, Dubi. I've got to share it.
What do you want to do?
Got to go into 1 second. Sorry, it's not.
Yeah. Okay.
What did I? Okay. Okay, so I have no disclosures. So the lecture outline, I'm going to present commonly ignored predisposing shoulder pathologies. And if we do address these shoulder pathologies, then we are more likely to get long-term results. I really haven't got time to talk about the literature, which I plan to in the 20-minute lecture. I'm going to talk about the regenerative principles to apply if you really want to maximize your results. I'm going to present some examples where to inject. And then I'm going to give you some simple exercises to prescribe also to maximize your therapeutic results. So, okay, so our aims in regenerative medicine, first of all, we want to strengthen we want to strengthen the structures around us. We want to strengthen the tendons, possibly even healing the small tears. I don't aim to repair massive tears, but we can definitely heal small tears. And even if in patients who have massive tears or large tears, we can still strengthen the supportive ligaments, supposedly to try and prevent this superior gliding of the humerus, and it can lead to rotator cuff arthropathy. So basically, we want to strengthen the structures that are viable and to prevent also further damage. So the tendons that we treat are the supraspinalis, the infraspinalis, and the subscapularis, not so much the teres minor. And the ligaments we can treat are the glenohumeral ligaments, which make up most of the capsule, the acromioclavicular ligaments, and the coracohumeral ligament, which I will talk about later. So there are several sorts of regenerative treatments. The cheapest one is dextrose prolotherapy, which is basically using dextrose of various concentrations. I use 20% in most of my treatments. You can use platelet-rich plasma or platelet-rich fibrinogen, which I use also. Some people use bone marrow, aspirate or concentrate. You can use fat injection, and also ozone, amniotic fluid, exosomes. I have absolutely no experience with the latter three, but they are also regenerative treatments. So I'm just going to show a few pictures of people with various shoulder dysfunctional pathologies. And I just want you to take a look at those and try and guess what pathology is going on here, what there is here. So here, looking at this boy here, you can see that both of his shoulders are higher than normal. They go, and the scapulae span from T1 to T6 instead of from T2 to T7. And both the scapula are adducted. Here you see a lady who's complaining of right shoulder pain. You can see that her right shoulder is lower than her left. Same with the right scapula. And both scapulae are downwardly rotated. I'm going to see myself so I can show my. Okay. Yeah, so both scapulae are downwardly rotated like this, which means that the scapula has to the rotator cuff has to work harder to achieve that 90-degree abduction. And I'm going to go into a little bit more detail This is a picture of a guy who leads a very sedentary life. He spends most of his day in front of the computer, and you can see that his scapulae or shoulders are very much forward, and his shoulders are sort of medially rotated. So this also compromises shoulder function, which I'll explain soon. And this is a picture of a lady with left shoulder pain. You can see that both scapulae are very much anteriorly tilted, like this, which will lead to compromise of the subacromial space, which I'll demonstrate soon. So the first phenomena of these, first of all, we must recognize that the scapula contributes to 1/3 of shoulder abduction. So if the scapula is not abducting properly, and it should be reach the mid-thoracic line here when we shoulder abduct, if the scapula doesn't abduct properly, then we have a lot more burden falling on the rotator cuff to do that movement. And we must recognize that there are 4 joints in the shoulder girdle. It's not just the glenohumeral joint. And if you have a dysfunctional acromioclavicular or even a sternoclavicular joint, and definitely the scapulothoracic joint, even though it's not a real synovial joint, if those aren't functioning properly, then the shoulder, the glenohumeral and the rotator cuff is going to suffer in one way or another. So I want everybody to stand up. This is a little exercise. Everybody stand up. And I want everybody to stand with your really slouched, with your shoulders sort of rounded and your shoulders medially rotated. Everybody do that. Get up. And your palms should be facing the back. I want to just demonstrate something it's much more extreme than what we see, but just to demonstrate a phenomenon. And when you're standing like that with your shoulders medially rotated, I want you to try and abduct your shoulders as much as you can. See where you get up to. And you'll see that you get to about 90 degrees, 100 degrees. Now I want you to stand upright, chin straight, arms by your sides. Your palms should be touching your thighs. And now I want you to abduct your shoulders all the way. And you'll see that automatically halfway through abducting, do it again, you'll see that at about 90 degrees, your shoulders laterally rotate. And this is a present that God gave to us so that our supraspinatus tendons can escape the acromion as we abduct. And this prevents a lot of wear and tear. So if a patient has limited lateral rotation, then there's going to be more wear and tear of the supraspinatus tendon with the impingement from the acromion. So therefore, it's very important to assess shoulder alignment. And if someone is not laterally rotating enough, we should give them exercises to strengthen their infraspinatus muscles. The third condition is the anterior tilting. So here I have a model of the shoulder. Okay, you can see this, one second, this is the anterior. Here is the coracoid coming here. And as you can see here in the diagram, you can see that the pectoralis minor tendon attaches to the coracoid process. And when it's short, it's going to pull that whole scapula down and forwards, which means that the coracoid is going to come down, but also the acromion is going to come down and forwards, which means that the whole subacromial space here is going to be diminished, which means that you're going to get more wear and tear of the supraspinatus of the rotator cuff. So if we see someone with anterior tilted shoulders and they haven't got a permanent deformity of a thoracic kyphosis, we can try stretching their pectoralis muscles, because that is what's doing it. That's the culprit of what's going on. And that takes a lot of perseverance to do that, but it's worth it. So the regenerative principles. First of all, we must recognize that multiple pathologies coexist, especially in chronic cases. Because when you have a problem on a particular structure, you're going to have the other structures around there, the neighboring structures, recruited to try and withstand that stress, those stresses. And we must understand that a stress doesn't fall on one little tendon. It falls on a region. And so if you're going to inject one little tendon, we can't expect to get long-term results. We have to address that whole structure, the whole region, if we want to get a good long-term results, and especially to prevent further damage. So the preventative principles we have to, the more thorough your approach will be to treatment of the shoulder girdle, the better and longer lasting your results will be. Also, not just addressing the tendons, we want to address the ligaments of the shoulder capsule, especially in the older people when they have massive tears and you want to prevent the superior gliding. I haven't done a study to show how this prevents it, but I have noticed that patients, even with massive tears, do improve in function if you treat this. So the ligaments of the caps of the shoulder actually provide a lot of stability. And so here is the coracohumeral ligament, which I'll talk about. Here is the superior glenohumeral ligament behind there. And here is the middle and the inferior glenohumeral ligaments. And of these, the most important are the inferior and the superior, which I'm going to talk about soon. And here also the coracoclavicular and coracoacromial ligaments, and the acromioclavicular ligaments as well. So just a quick look at the shoulder under ultrasound. So we want to expose the supraspinatus, which is normally under the acromion. So in order to see that under ultrasound, we have to medially rotate that shoulder and put it behind on the back pocket. So you can see that the probe is aligned with the humerus here. And this is a longitudinal view of the supraspinatus tendon. You can see the footprint on the greater tuberosity. And here is the humeral head. And here is a thin line of cartilage over here over the top. And you can see that the fibers are very nicely aligned along the supraspinatus, area. All these fibers are very nicely aligned. This is not a tear, okay? It means that it's at anisotropy. In other words, because the fibers are coming in from a different direction, they're not perpendicular to the probe, and therefore they're going to look black and hypoechoic or anechoic. But if you just toggle the probe around, then you'll see that. If you want to rotate that probe around 90 degrees and look at that on short axis, in other words, the fibers normally are coming sort of down across from under the acromion and inserting this way. But if you want to look cross section in that way, then you turn the probe 90 degrees. And you'll see here is the humeral head, here's the cartilage, and here is a nice thick supraspinatus tendon. It's all even, uniformly even in height and width, and that's a beautiful tendon. So that's a short axis view. So the type of tears, okay, so here's a normal supraspinatus tendon. This is the bursal side. Here is the articular side. Here is the imprint on the greater tuberosity, okay, that's normal. The articular-sided tear, a partial reticular-sided tear, is on the articular side, as the name implies. So you have a tear that doesn't go the full thickness. If you tear, a full thickness tear doesn't mean it goes the whole width across the joint. It means that it goes the whole depth of the tendon. So if a full thickness tear would go all the way from the bursal side to the articular side. And here you see a partial tear, a demonstration of a partial tear that goes from the cartilaginous side, some partially halfway up or some of the way up through the thickness. And these are the sort of tears you get in the elderly, which, by the way, are more amenable to treatment. The bursal-sided tears are what you get more commonly with athletes, and these are more difficult to repair. They have a poorer prognosis. So the tear is on the bursal side, as indicated, and because there's no tissue there, you sort of get a gap in the tissue there, and the bursa falls, and you sort of see that sort of, I mean, I've exaggerated it here for demonstration, but that's sort of what you see. You sort of see a sort of a dip. And these are more difficult to repair. So this is the subscapularis coming up. Subscapularis comes across from in front of the scapula across to insert into the lesser tuberosity. So this is laterally towards the lesser tuberosity. You can see the subscapularis here. This is a long axis. And here is the side of the coracoid. You can see that's normal. And here is, I haven't got time to show all the views of all the tendons, but here is the infraspinatus, also long axis. Sorry, there's a spelling mistake here. It should be L-O-N-G. And you can see that here's the infraspinatus tendon. It looks really nice, beautiful parallel fibers going across. Here is the humeral head. Whoops. Humeral head and the cartilage across there. It's got a nice level of cartilage. If you go a little bit more laterally this way, you will see the tendon sort of thinning out and sort of inserting into the lateral facet of the greater tuberosity. So I'm just presenting a few pictures of patients who I treated with prolotherapy in the public clinic in Hadassah. This is a picture of an ultrasound picture of a guy of his supraspinatus tendon. He was injured in a terrorist attack. His bullet went sort of from the side through his supraspinatus, coming from the front actually through the supraspinatus, then back at the infraspinatus, coming out of the infraspinatus, and then tracking up the back towards his neck. You can see he's got a fracture here in the greater tuberosity. And you can see this sort of partial thickness tear sort of going along here. It doesn't quite get the full thickness. Okay, if you take it in short axis with the probe this way, so you see the fibers coming across, you see that the wick hasn't dipped, it hasn't dropped. Okay, you've still got fibers more or less the complete here, and you see this break here, so you can't see underneath the calcium. So it's okay, and so you can see the tendon, the tear is partial. But this is after 2 treatments on the right-hand side. You can see that the fracture is healing, which it probably would have without the treatment also. But you can see that these gaps are sort of filling up with collagen tissue. It's not, you don't expect to see a full, complete repair after 2 months, or even less. It was about 6 weeks. But you can see it's starting to fill up. And here also in the short axis, you can see that the fracture is healing, and this is sort of filling up with collagen tissue. This is of a lady, of 84-year-old lady. You can see her subacromial bursa is dramatically inflamed. Her supraspinatus tendon is basically sort of mostly torn. And after 2 or 3 treatments, I can't remember, but you can see that first of all, the inflammation of the subacromial space has subsided considerably, even though I didn't actually inject the subacromial bursa at all. I just injected the tendon. And you can see also the gaps are starting to fill up with collagen tissue. And here's a guy with the subscapularis tear. He had a 9mm tear in the subscapularis before treatment, and after treatment, that is filling up with collagen tissue. And that's all with just simple sugar injections. A lady with a 6mm tear. These pictures aren't so great, but this is from done by an ultrasonographer. He saw that this is all the other pictures were my pictures. Okay, this is done by an ultrasonographer. He saw the 6mm tear in the infraspinatus, and here is not a fantastic picture. It looks pretty hypoechoic, but this area here where the tear was is, as he defined it, was completely healed. So the importance of the rotator cuff interval. Okay, this is really important because this has a critical role in stabilizing the whole rotator cuff. So on the right-hand side, you see the lesser tuberosity. This is all in cross-section, okay? The lesser tuberosity here, the greater tuberosity here, the subscapularis inserting into here, the supraspinalis coming sort of towards here. And over the top of, this is the bicipital groove, okay? So that's the rotator cuff interval is basically from the greater to the lesser tuberosities. It basically includes the bicipital groove and everything in between. And across the top, you could see the coracohumeral ligament, which plays a very, very pivotal role, if I want to say it. So the coracohumeral has a, the medial side of the coracohumeral ligament and the lateral side of the coracohumeral ligament. And it's sort of compressing down on the whole thing, providing a stabilizing force. And here is the supraglenohumeral ligament, which sort of comes across and inserts next to the long head of biceps tendon. So if you have a tear in the supraglenohumeral ligament, then it's going to provide less stability, and one's much more vulnerable to then progress to a partial tear of the supraspinatus or the subscapularis, and that can spread and degenerate more and more. And then you get both. So we want, when I treat someone with a partial tear, I invariably treat this whole structure. So I'm coming, this is the lateral side, this is medial. You can see the greater tuberosity here, the bicipital groove here. Here's the long head of biceps tendon. Here is the supraglenohumeral ligament. And here is the subscapularis tendon. So here is a picture down below. I've got a needle coming, you can see the needle coming out down here. And with one jab, I'm injecting about 4 or 5 points. So I come in from the lateral, I'm injecting some of the fibers coming medial as far as it does from the supraspinatus, and inject the lateral coracohumeral ligament fibers. I'll go into the bicipital groove and inject the supraglenohumeral ligament. I'll pull that out, the needle out a bit, and then I'll inject here into the lesser tuberosity and onto the medial coracohumeral fibers. And then I'll pull out and inject the, and then I'll inject the subscapularis insertion. So with one prick, one jab, I'm doing 5 points. And each point I'm injecting just about 0.4, 0.5 cc's, absolute maximum, no more. So once we've also done our treatments, we want to maximize our therapeutic results, and we're treating the whole functional unit. And we talked about people, let's say, who don't have enough scapular abduction. So we want to release those muscles, and we can use dry needling. You can use stretches, but you can use dry needling to release those muscles very effectively. Here, when I'm needling the attachment of the rhomboids to the scapula, this is just needling the, you can't really see that, but that's just a diagram, needling the trapezius muscle. And lastly, last but not least, is some exercises. So this is an exercise strengthening the infraspinalis muscle for people with medially rotated shoulders. To do that, you sort of abduct your shoulder, your arm so it's 90 degrees abducted, and the elbow is flexed 90 degrees. So you're standing with like this, sort of, you can't see me properly, but standing like this, your arms out like that. And I just tell my patients, even if to do it without a weight, or to take a kilo of sugar or flour or something, and to just sort of flop their arms backwards and forwards. I often ask my patients when they see me, are you flying? You know, they know what I mean. Are you doing their infraspinalis exercises? Just like that. It's very important. And the last exercise is of the pectoralis minor, to stretch it. And you can see lots of exercises on YouTube. You can go in and see how to do that. Make sure that it's not pec major, because that's a different muscle, although it may also be of benefit to these people, but pec minor is the exercise to do. And that has to be done religiously to have an effect on that. So if you want to get good results treating partial tears or any shoulder problem or any musculoskeletal problem, your treatment has to really follow a very methodical assessment. And you should address the contributing postural factors. You have to consider that multiple pathologies coexist, especially in chronic cases. And your treatment should address the whole functional unit if you want to get good results. So thank you very much for this honor. It was a pleasure to be part of this. And all the best.
Questions?
If you have any questions, I don't know if there's time for questions, but thank you very much. And thank you very much to Laura. I know I actually want to see Laura, meet her after all our emails.